Thank you so much, Sophie. It's really lovely to see everybody. I'm just delighted that this event is going on, and so grateful to you all for the work that you're doing, both as practitioners and as researchers. It's absolutely critical that we get more research in this area. One of the things that is astonishing about social care is how big it is, and yet how little attention it receives. There are more than 1.5 million people working in this sector. That's very broadly the same number as in the NHS, but it is almost completely invisible. And that's bad for both the consumers of social care and the providers of social care. And it means that we're not making as much progress as we should. Because of time, I'm going to speak mainly about, in fact, I think entirely about social care for older people this morning. Although that's not because I think social care for working age adults and for children is less important. It's different, and the issues, particularly the funding related issues, are different. I think the research related issues are different because of the numbers that we're talking about in elderly social care. I'm going to try sharing my screen because my own professional background is as an economist. And economists find it very difficult to speak for very long without putting up a PowerPoint slide. It's just, you know, and there's no way of getting that out of us. But before I begin, let me say that as I've reflected on what I should say over the last few days, the thing that I've been most struck by and that I most want to get across is the diversity of people's needs and experiences, and the importance of uncovering that in our policy, in our practice, but also in our research. As I say, the thing I'm going to emphasize most is diversity, dispersion, difference, that we should acknowledge, investigate, think about how we can do things better, but that will make for great research. So anyway, let me just share my screen. The first thing I want to emphasize is that people often look back to a kind of golden age of social care for older people when Granny was being looked after by her extended family. Well, this is just completely wrong. Granny wasn't being looked after by her extended family 100 years ago. Granny was dead. So in 1901, and this is not on the slide, but in 1901, the 1901 census tells us there were 61,000 people aged 85 and over. Now there are about 1.5 million people aged 85 and over. There has been an astonishing transformation, and this has been achieved by people simply living for much longer. So this red line on the chart is the proportion of the cohort that were born in 1905 that survived to particular ages. So you can see the tragedy of infant mortality at the beginning of the last century. By the age of 5, we only had about 80% as many people as we'd had 5 years before. And then deaths continue through adulthood and then start increasing very rapidly from the age of about 55. So very few of the cohort that was born in 1905 lived to the age even of 85. Very, very few over the age of 90. Look what's happened. By 1930, the cohort born in 1930, so my parents' generation, infant mortality has dropped away very significantly. Mortality through the prime of adult life is much lower. And so we have many more people living to older ages. By 1955, so my older siblings, it's transformed again. Infant mortality has dropped away, but we've got a staggering increase in the number of people living to the age of 60. Of course, we don't know how many of them will live beyond the age of 60 because that's the future for most of them. But we've moved from, in the 1905 cohort, we had about, at age 65, we had fewer than 60% of them still alive. We're expecting 85% of that cohort still alive. And it looks as though these increases in mortality, these increases in longevity will continue. So we've moved from a very small population potentially needing social care as older people to a massively larger population. And thinking hard about the consequences of that for who's there, who needs social care, what's their gender, because mortality is strongly affected by gender, what's their prior health experience, what kind of family and informal care do they have available. These things will be changing, have changed astonishingly rapidly, and we don't know very much about them. there are other things that have changed astonishingly quickly. This slightly complicated looking chart shows from 2000, so only 20 years ago, the share of the older population with by number of long-term conditions. So the red bars at the bottom are the share of that older group that has no identified long-term conditions, and you see that's fallen from about 58% to about 32%. And then the green bars above it are those with one long-term condition, 2, 3, 4. And what you can see is that the number of people with multiple identified long-term conditions has grown massively in the relatively recent period. Now, what's not absolutely clear is whether that's because the number of people with these conditions has grown massively, or the number of people with these conditions who are identified as having these conditions has grown rapidly. But given the presence of this really complicated comorbidity for many of the people who will be in this population, there must be huge numbers of questions to ask about the nature of the health and social care treatment that is available, the availability within social care of expertise to support people with multiple conditions, questions about whether we have siloed care or not, questions about whether these diagnoses are accurate given the rapidity with which it's been increasing. So that's another way in which we now at least see astonishing dispersion in the experience of older people. And surely it must be the case that those changes ought to be having a really rapid and significant impact on the way in which care is being provided, both domiciliary care and residential and nursing care. One of the characteristics of the policy debate in this area is a kind of assumption that people are homogenous, that to the extent there are any differences at all, it's differences between some people who only need domiciliary care and some people who just need residential care. What we see in all of this is actually an astonishing diversity of experience, and my own sense is that neither policy nor research understanding has caught up with that. All of this is going on at a time when we're simply not spending enough money on social care. So what this chart shows is just for the last 10 years or so, starting in 2010, what's happened to an index of spending, which is the red line. So spending in real terms fell for a few years and then has risen in the last 4 or 5 years somewhat. The blue line adjusts for the number of people. So there's been a significant increase in the number of older people. And then the purple line at the bottom adjusts for age within that population. You see that age adjusted, we're now spending about 87% as much as we were in 2010 on elderly social care. It is no surprise that the system is creaking desperately at the seams. There are all sorts of research questions we need to answer here. Who's not getting care that was? Because we know that the number of people getting social care provided by the local authority has significantly reduced. Well, why? Is it, this would be the nicest story, that fewer people need social care? Because although there are more older people and that demographic change has been going on, the new generations of older people are fitter and healthier and less needing care than before? Or is it that the eligibility criteria that we're applying are now so tight that people who in previous years would have been entitled to some support from local authority social care are no longer getting it? If so, what kinds of people is that affecting? Are there particular groups who are being excluded, or is this happening absolutely across the board? Is this happening in uneven ways across the country? Is it, for example, the case that in rural areas or urban areas, it's more likely that the squeeze has occurred? Are there patterns across political support? We desperately need to know answers to those kinds of questions, and we simply don't. Then let me talk briefly about funding more generally and how we thought about this in the Commission, and what I think that also tells us about important research questions. This is a chart which, imagine that we took 100 65-year-old people drawn at random from the population, and we lined them up in order of how much social care they were going to need before they died, that somehow we'd become omniscient and we knew. We'd find that about 20% of that group of 65-year-olds would be walking up Snowdon at the age of 90, fully fit, would have a heart attack and die immediately, and would never need any social care. 80% of us are going to need social care, and by needing social care, I mean need social care badly enough that we pass the local authority eligibility assessment. But the person in the middle, the median person, will probably only need about £20,000 worth of social care before dying, the equivalent of perhaps 6 months in a residential care home or maybe a year or two of domiciliary care. But the really interesting, to an economist, feature of social care is that from the middle on, it then starts rising very rapidly. And the person at the far end, let's imagine that you have such severe arthritis that you need to be admitted to a residential care facility when you're 65 and you live for another 30 years. Then we're talking about £1 million worth of social care. And if you're a couple, £2 million worth of social care. Now, of course, that's unlikely, but it's not infeasible. And this is why social care is so terrifying for individuals, that faced by a risk like this, we don't know what to do. Other risks that have this kind of shape are the chance of your being involved in a car crash, or your house burning down, or you having a very severe health problem. In all of those cases, we do what economists in a kind of ugly phrase call risk pooling, or all the rest of us call insurance. We do this. We say, in the case of houses and cars, you must buy insurance, which pools your risk. And so some of us will end up having paid insurance premium and never claiming. And some of us will pay insurance premium and claim. In the case of healthcare, we do that through the state. So no individual in this country faces the financial consequences of a serious health problem. We pool the risk completely. We pay taxes, which pay for the NHS. Social care is the one big risk that we all face where this risk pooling is not available, because the care that the state will pay for is entirely means tested, and the private sector will not provide insurance in this area. So this quote, "magic of averages to the rescue of the masses," is something that Winston Churchill first said in 1911, after he'd been involved in the introduction of social insurance, initially for unemployment. And then he came back to it in 1943 in a speech he made on the 21st of March, 1943, when it was becoming clear that the Allies expected to win the Second World War. And so he set out the plan for the first 4 years of peace. Much of it was about Europe, but he then moves on to a couple of paragraphs about social insurance. And he begins by saying, "I've been a strong advocate of social insurance arrangements for 35 years, during which I've worked with my initially young friend, William Beveridge, who helped me set up the labour exchanges in 1908. And then he says something like, "Our social insurance mechanisms in the UK are already incomparable, and I'm a great supporter of them. Social insurance, as I first said 35 years ago, can bring the magic of averages to the rescue of the millions. And you can count me and my colleagues as staunch supporters of social insurance for all classes against every risk from the cradle to the grave." That phrase, which I'd always thought was a Bevin phrase and a Beveridge phrase, actually Churchill uses in 1943. This is the one area of the welfare state where we haven't yet achieved social insurance, the bringing of the magic of averages to the rescue of the masses, and we must. We could, of course, go for an NHS model, which would take all social care into state provision. I think the political chances of that are very close to zero. If we're not going to go to an NHS model, then we should do what we outlined in the Commission report 10 years ago, which is that the state should take the tail end risk, the catastrophic risk. So we should put a cap on the amount of cost that any individual should face over her or his lifetime, taking away the fear of complete loss of control and losing everything. Why might that be important? The reason that's important is that at the moment, we don't, as we have in the NHS, have in social care a state-directed regime. We have essentially still a private sector market. But we have a market where the consumers are completely powerless. So buying social care is like being in a shop with no prices, because although you know how much it will cost to have your husband cared for or your mother or grandfather cared for each week, you don't know how many weeks or months that will go on for. So you don't actually know what the price will be. Faced by that, all but the very richest feel paralyzed and so look to spend the least that they possibly can as long as it meets the regulatory requirements. That means we don't have a well-functioning market. And the thing that can be great about a market is that a market can encourage innovation, change and investment on the part of producers, and encourage learning amongst consumers, learning from consumers about what it is that they want. And at the moment in social care, we just don't really understand what consumers want. There are more than 500,000 people receiving social care as older people in the UK every year. We don't really know what it is that they want, nor do we know what it is that we achieve by the things that we provide for them. We need massively better understanding of what it is that individuals would like from social care, what it is that individuals, families and supporters would like from social care, and what the outcomes of social care should be. We surely don't simply want to think that all we're trying to do is keep people alive. Of course, we're trying to keep people alive. That's the absolute minimum. But what are the other things that we might be trying to achieve through the provision of social care? Which aspects of people's lives can we ensure continue to be fruitful, enjoyable, dignified, and worthwhile? And how can we innovate and invest to do better? A great deal of that comes down to the funding regime and getting a funding regime that allows people to make some choices and allows people no longer to be fearful. But there's also a huge amount of research to be done, framing questions about what the appropriate outcomes that we should be looking for are, framing questions with service users about what it is that they want, what it is that they enjoy, what it is that gives them satisfaction and delight. All of these things can be done, but they can only be done if we have the courage, which we've so far failed to have, to spend enough on social care as a society and to have the political will to get some significant reform done.